Thank you. Welcome back. We're ready to start panel 2. We're right on the dot, right on 11:15. So I'm going to introduce the party who is going to introduce panel 2. Let me tell you about Beth Elson. Beth Ellison is a behavioral scientist at MITRE. She spearheaded the development of game technology to boost emotional intelligence. This is going to be a really big program, okay? Please join me in welcoming Beth Elson to the podium.
Good morning, everyone. I'm Beth Elson, and I'm happy to say, on my 4th year attending the Hero's Journey Symposium. Welcome to Panel 2, Innovative Approaches to Mental Health Treatments to Improve Patient-Centered Care. In Panel 2, we'll focus on how we can use technology to connect people to the right type of care and how we can leverage innovative approaches to help people in their journey toward mental health. We have a power-packed group of panelists at the forefront of innovation in mental health. Our panelists include current and former service members spanning both the U.S. and the U.K., as well as leaders in the for-profit, nonprofit, and public sectors. Dr. Tamara Campbell, an Air Force veteran, serves as the Executive Director of the Veterans Health Administration Office of Mental Health. She oversees the development, implementation, and operational integrity of the VHA programs that provide veterans access to a full continuum of integrated mental health care services. Dr. Ejus Neenan serves as the Clinical Director for the Joint Warrior Care Recovery Coordination Programs in the National Capital Region. He's a healthcare executive and mental health clinician dedicated to fostering a healing environment and supporting the recovery, rehabilitation, and reintegration of our nation's wounded, ill, and injured service members. Josh Otero is the co-founder and CEO of Elana.ai, pioneering AI-driven mental health solutions for veterans, service members, and their families. He's also the founder of the Warrior GMR Foundation, empowering veterans through gaming, mental wellness, and community. Air Commodore Sonia Fithian left the UK Royal Air Force earlier this month after serving for 30 years. Describing herself as an operational nurse, her military career has exposed her to the full spectrum of global medical support to UK defense. Sonia is now Director of Services for Combat Stress, the UK's leading charity delivering specialist treatment for veterans with complex mental health needs. Leading us through the panel discussion is our facilitator, Kim Albero, a veteran Navy nurse with experience in shipboard and combat flight operations in the delivery of care and movement of patients in austere and remote areas. So please, join me in welcoming our panelists. Without any further ado, I'll turn the panel over to Kim.
I want to welcome each of you, and thank you so much for being here. Each of you has a unique role in helping wounded warriors, active duty service members, and veterans in their healing journey from traumatic experience through clinical care and then into a community of veterans who have lived a traumatic experience, healed from it, and now want to integrate that into their lives. And I'd love to hear from each of you about that work that you're doing. I'm going to start on the end here and hear a little bit about the Mental Health Care and Wounded Warrior Project from the active duty standpoint.
Well, thank you. Thank you for having me today. Truly appreciate the opportunity to be able to have this discussion. I do have to first state a disclaimer. All the opinions are my own and does not represent the Department of War at this time. So starting off, I am active duty. I am a mental health provider, but I'm in a unique spot right now where I have an opportunity to take care of our wounded, ill, and injured from the moment of medevac, when from a combat zone or a austere environment where they're coming through to the moment of reintegration. That means once they come through the medevac, we have an opportunity to interact with them and their family members. Sometimes they're coming through Landstuhl, families already have arrived. So when they're on their medevac, they're actually coming through with their family members. So it's a full integration piece. One of the key things is that our patients may go into, are wounded are going to go in inpatient and go through a whole process of treatments that they're going through. And so that's where I look at is the innovative part of the mental health piece where my team is able to engage. We do the inpatient liaison program where we're part of the mental health, we're part of the multidisciplinary trauma team, but in that we're able to advocate for the patient. We're able to be there for the family members to ensure that they're understanding what's going on. A lot of the family members have never had an experience in the military system, so coming in is very scary, it's very daunting, not really sure of how to work in that environment. So we kind of become their voice. We also, and some of our service members that come through may have no family members. They're coming straight out of the combat zone. We still are receiving, I think that's one of the key things that we have to realize, that we're still receiving wounded, ill, and injured from austere combat zones that are still happening on a regular daily basis. And so in these environments, when they come by themselves, we become that voice for them also to ensure, hey, their garbage wasn't taken out, or they haven't had a bath, or they need, they don't have a cell phone, they don't have any contact, they don't have clothes. They might, sometimes there's so many just small parts, so it's like that environmental aspect of just that social connection, to know that someone's there for them. From there, we ensure that they have a comprehensive treatment plan, and then depending on if they're going back to their unit or not. The other part that our program really does, and again, that's where it comes to the mental health piece, is really that contact with the command. Someone needs to be able to talk to those commands. I've had 52 months of deployments, I've been a commander myself, and in those moments that I look at is not knowing what's happening to my service member is scary, and I'm not there. I'm not physically there, and I need to know. And usually sometimes when I speak to a medical provider, they're so focused on the treatment and ensuring that they're not in pain or we're getting the right care, they don't have the ability or time or the know-how on how to communicate with the commander. So we become that voice, that liaison between that command team. And once that happens, a lot of times we got to cut orders. We have all these other aspects to ensure that we can take them on for their full care. And that's where the reintegration piece or recovery piece comes in. Recovery is a long journey. And we have some of the best services that's possible, especially when it comes to wound care. But in order to do that, you have to go through the process. So we also house all of our wounded, ill, and injured in the National Capital Region, in our Wounded Warrior Barracks or temporary lodging area. And so that's one process. Sometimes we have family members, they're also able to stay there through the Fisher House programs that we have. So ensuring that there's patient placement so that they can have access to the right care at the right place at the right time, and ensuring that if they need to get back to the ER, you're 2 minutes away, we can roll you down to get there. It's really, we're up on a hill, so you do roll down the hill. But the other part of that is where we create community. The biggest part for me, I was a wounded warrior in 2003 after Iraq, and spent about 4 or 5 months in the old Bethesda, Walter Reed. And one of the key things was the loss of identity, loss of unity, loss of just personal independence. And it's a moment of isolation. And so what the comprehensive piece of it is ensuring that there's a social prescription that's given to them. So as a therapist, I can say, you can come into my office, I can provide you with mental health care, but that we found to being patient-centered, you have to help them find their purpose. And you have to really look at, is not what's wrong with you, or what, it's really what matters to you. And helping them to identify what matters to them is the main piece of ensuring. So we have a comprehensive social program, ensuring that they have connection and activity. So it is, and that's why I love seeing here, we have a huge partnership. And we're going to have the next panels actually talk about those other opportunities, but equine therapies, looking at adaptive sports, but community-based engagement to have that catchment in their healing process, because that medical piece isn't the only piece. We have to look at the social determinants to be able to do that piece to it. So that's where that recovery comes in, which comes into transition and reintegration. So I'll talk afterward as we continue on the mental health piece, but that looks at it from a holistic approach of how do you take care of that moment, the moment of medevac to the moment of when they come through and either return to duty or, and right now we're having a really high return to duty rate. So either return to duty or transitioning back into a civilian life.
Yeah, I think it's so interesting that, you know, people will deploy from wherever they are based, which might be California or North Carolina, and then if they're wounded, they come back to the National Capital Region, which a lot of people haven't even visited. So to have family members able to come and to be nearby and help to reintegrate sounds like a great thing that you all are doing. Sonia, I'd like to hear about your work and how you're helping the Wounded Warriors in the UK.
Yeah, thank you. I'm very humbled to be here, so thank you for the invitation. So Combat Stress is the only charity in the UK that actually does what it does, which is supporting veterans with military-related trauma to their mental health. It's quite old, so it was established in 1919, just after World War I. It was a group of women that came together, recognising that soldiers and veterans were affected by the war emotionally or mental health, and they wanted to help them recover. And it was a time, as you can imagine, when there was a lot of stigma and mental health was not understood. It's evolved over that time, but at the core it still does what it does, which is supporting the veteran, but also the veterans' network as well, whether that's their family or their chosen family as well. So the focus is very much on the recovery of the person. We accept referrals from an individual veteran or a professional referral. We have a 24/7 helpline where a veteran can contact, or a family member can contact the helpline and just talk. And then from that point on, we sort of wrap our arms around them, and we will either identify that we as a charity can help them, or we need to signpost them to somewhere else where they perhaps need help if maybe the challenges are more financial or domestic or housing or something like that. So in the UK, we've got around 2.5 million veterans that we know of. It's probably like here, it's quite hard to often get that accurate figure. And so far this year, we've supported 20,000 in some way. Around 13,000 are veterans themselves and 7,000 are from their family members, with around 1,500 actually receiving treatment from us. So the treatment is very bespoke, and it's whatever that veteran needs to take them through, and it can be sort of very more low level but key significant problems all the way to complex mental health challenges. And we do have a very good recovery rate, where those who come with complex mental health problems at the end of their treatment, 73% of them no longer meet that threshold. So I think that's a really good takeaway. Yeah, so that's in a nutshell what Combat Stress does.
Well, that sounds like a great organization, and we'll hear more about it as our discussion continues. Josh, we talked a little about building some community in the immediate post-injury clinical care time frame. Can you tell us a little bit about your work and how it helps to bring veterans together?
Absolutely, yeah. And to paint a little picture, flashback to 2020 and what happened in 2020. We had COVID spiking, we had social isolation, distancing. We couldn't get together. And what I saw was this huge spike in social isolation, loneliness, depression, ultimately leading to suicide. It's because we need connection. And so there were two events that really sparked me to do something. In February, there were 2 cadets at the Air Force Academy that took their life. A couple months later, 6 sailors did the same that were stuck on a ship. And so 2 months after that, I started the Warrior Gamer Foundation with the whole mission to promote health, wellness, and community through gaming. Because I saw gaming, even though we're socially isolated, we could connect through gaming. And so, whether it's through, playing games, connecting on Discord, which we'll get into later. I saw gaming as a powerful tool to be able to do that. And then we started to put on these mental health summits, and then we started to learn more about the community and the role that the community plays. So once we started going in that direction, there was a company that I started because I saw the advent of technology, and technology is a connection tool, which is a company called Ilana.ai, which we'll get into later. But that's a little bit about the connection port. There's a couple things that I'll touch on later. Belonging, a sense of belonging, sense of purpose, and a sense of community. That's extremely important. Those are three pillars of the foundation that we've heard from both the keynote speaker and the panel number one. So we'll touch on those later.
Sounds good. Excellent. And a woman with a very, very important job and a large number of, we'll call them customers. But can you tell us a little bit about the Veterans Health Administration and all of the advances in the mental health services that are being provided to veterans?
Certainly, and I really appreciate the opportunity to be here. It's an honor, and to be on this panel with such distinguished guests. Veterans Healthcare, as you may know, is the largest integrated healthcare system in our country. There are about 20 million veterans in the United States. 9 million of those veterans are currently enrolled in healthcare. And so it's programs like these that are going to help us close the gap on getting those veterans that are not currently enrolled tethered in some way, either within the direct VA healthcare system or within the community. The largest growing demographic in VA are women veterans. We have about 900,000 women veterans enrolled. 300,000 of those women are of childbearing years. And that is critical because they are young, they have multitask with family, children, and we need to embrace all that they have to bring. Our veterans are resilient, and so we are moving from a disease model of mental health to a recovery model, where the expectation is treatment works, and our goal is to reintegrate that veteran in the community. So veterans may come to us for care, they do come to us for care, but they actually live in communities. And so it's really critical that we partner with the communities that the veterans are in. We have a full continuum of care from our mobile apps. We have about 20 award-winning mobile apps, to include CBTI for insomnia, PTSD, meditation, and then we have the most restrictive, of course, is our inpatient units. Least restricted are the mobile apps. In between are the outpatient treatments. We have residential treatments, focusing on our substance use disorder. We have a very complicated population, so that you will not find a veteran more than likely with just one issue that they're addressing. A lot of comorbidity with substance use. And then our homeless population, we have an entire homeless program, because we know at the bottom of Maslow's hierarchy is food, clothing, and shelter. And so if you're not taking care of that, it's hard for someone to want to come for 9 to 12 sessions and they're not able to take care of their basic needs and their family needs. And so it's really critical, as I mentioned, that we partner with the community. VA cannot do it all and cannot certainly do it alone. Those social determinants of health are critical. We know that with our suicide numbers, and one suicide is one too many, that many of those veterans aren't tethered to mental health, and some of the issues that they're dealing with are not necessarily mental health issues. Sometimes they're financial issues, sometimes it's employment. What I learned myself being in the military is that our armed services are very talented, and they do a lot of high-level jobs that the community really isn't familiar with. And so sometimes there isn't a direct, what we call occupational code. So the mental health tech in the armed services They run groups, they do assessments, they get everything ready before that doctor enters the room. There isn't always a direct line of that occupation in the community. And so our active duty members will get off active duty and they're like, I did these high-level jobs, and not just in healthcare, but other areas. I did these high-level jobs and really important jobs in the military, and like the community is not aware of this, or there's nowhere for me to transfer this talent that I have. And that's a loss of identity that we're dealing with. We know that that first year of transition out of the service is critical. There's a lot of high-risk vulnerability in that space, and so we need to make sure that before they come off active duty, we have touched them in some way, and they know that that we're here for them.
That's wonderful. And I can speak for myself as a veteran, having come off active duty. And being a healthcare provider, I thought it was pretty easy to figure out how to file a disability claim and then get health care, except it turned out to be more steps than I realized. And then when my husband came off active duty as a Marine Corps officer, he was an artillery officer. And to translate, you know, firing a cannon and blowing things up very far away into something that would be useful in Charlottesville, Virginia, was challenging in terms of being able to articulate the skills that he had, and you know, what we used to call soft skills, but I call power skills, and just the leadership that a lot of service members have had and responsibility that they've had, trying to impress that upon someone who looks at a young person, someone in their 20s or 30s, and thinks that they have little to no experience, when really, you know, we both come out of the service with that identity as having served, but also with a need to articulate what that service not only meant to us personally, but how we can benefit. And a lot of us come out of the service wanting to continue to serve, you know, caring about our fellow service members and our fellow Americans. So finding things like that and knowing that the VA is there to help is for myself, has been a wonderful piece of comfort for where I am. I want to talk a little bit, we talked about the clinical care and some of the connections that can be made among veterans and service members. Can you talk, I'll actually start with you, Josh, a little bit about the outreach piece, how you kind of find people who would look for that connection, whether they are veterans and, you know, have their DD 214 to prove it, or, you know, have experience assisting with war efforts that maybe didn't involve a uniform.
Yeah, that's a challenge. I mean, it's just like the VA is having a challenge of getting people. We leverage social media, and we leverage word of mouth. Mm-hmm. Those are really two of our biggest areas, and there's a platform called Discord, which Discord is really a community which we really utilize to as big of an extent as we can. And through word of mouth, the VA puts us out, so we go to, you know, 14.5 million veterans, and then whether it's Facebook, Instagram, people put us in TikTok, and then they reach out to us. But social media and outreach are our two biggest methods that we do, and then we put on these big mental health summits where people see us and then they become a part of the organization. So those are, I would say, our biggest outreach areas.
Interesting. And Sonia, I have the same question for you about how people find out about your program and services that you provide.
And I think that the targeting of how you raise your profile is really important. And I think for us, we've just done a review so that we can be dynamic and quite adaptive to reaching out to the different generations. There's 1,600 military charities in the UK. So it's quite congested, and I think it is hard sometimes for veterans to know which charity do they go to, for what need. A lot of it is done by word of mouth, from that sharing of good experiences as well. And I think there's an importance to be alive to how you do raise your profile, because the age group that we are targeting is changing as well. So the average age of the person that comes to Combat Stress for help at the moment is 46, but it is starting to drop. And that's really important. We know that the average length of time it takes somebody to come to request help takes 14 years. So somebody has lived for 14 years with some kind of health need that hasn't been met. And we are seeing that age drop and will probably continue to drop. So I think that's where we need to be alive to how do you reach those people? And because it's probably not through radio and television anymore, it is through social media platforms really. What we do a lot of investing in is co-production as well. So we really do invest in understanding what worked for veterans that have gone through combat stress treatment, and then we take their feedback and from their families as well in order to try and make sure that our services are adaptive to the future need.
Interesting. And you mentioned the name of your work is Combat Stress. We talk about the combat stress continuum and how we as active duty service members measure our own emotional and mental barometer around things that are happening, and not just as a part of work, but as a part of life at home, which always impacts how work is done. I wonder if you could tell us a little bit about your integration of the concept of combat stress and helping wounded warriors to understand, where they are and when they start to feel better, feel like they've moved perhaps from the red to the orange or from the orange to the yellow, in terms of having a little bit more stability around recovery and their physical recovery, and then ultimately their mental health and community.
So I think each of you brought up a really great part, and I want to kind of take it one step further rather than just the wounded warrior side. And I think that comes from the advocacy that we are doing here. Was the Brandon Act that came out. And I would say that removed a lot of the barriers that previously existed for maybe not senior leaders, but more for our junior service members to come and seek services. And they can kind of, without having to go through their unit, without having to be the command being notified, so that they can go ahead and have immediate access. The second part to it is the behavioral health community had to come in and integrate and really evolve. And so it actually took place in 2013, where we stepped out of our comfort zone. And I'm Army now, prior Marine Corps, but I want to give Army a little bit of a highlight on what they did. Because in 2013, it actually started in 2010, and we started to think about it. But 2013, they went out to Sloan, MIT, right, and got people to come in and start doing action research, right? And we did a huge systematic review and started to say, how do we provide care to our service members, and especially mental health care? And so that's where the embedded behavioral health teams came in. So embedded behavioral teams mean each brigade received a modular 13-person team that was in the footprint. So that was a big change. We changed it from coming to the hospital to being mental health in the footprint, having and then being very still combat focused. So the fact that you coming to get care, one, getting to the appointment was that access was difficult. This now gave you immediate access. The second is it was a ongoing communication with the units. So we may not talk to the units. So what happens is now that in a hospital you were seeing from like 20, 30 different units. This now you're seeing from this brigade, and we had people aligned to a particular battalion. And so now we can get more data of, hey, this unit or this team is having a high level of, I just saw 30 people from this team, right? We need to probably have some intervention. But what happened is we got buy-in from the brigade commands, where those embedded teams were actually part of the conversation in the health and welfare meetings that we were having at the larger level. right? So that's one of the implementations that took place. But the other part is transforming substance use care into, so it used to be ASAP, and it was part of the installation. We took it back into SUTCC, substance use clinical care, and understanding to see that it had to be integrated. So we took substance use care and integrated it into family advocacy programs, into the multi-ID programs, into the actual primary care teams. And so what we did is you had to integrate and understand the level of, and it wasn't just, when you say SUTCC, it was actually addiction services, right? So it's not just for, because we do have a high rate of eating disorders. We have high rates of other types of addictions that service members kind of are struggling with, right? And so we were able to now comprehensively address it with the IBHC level in the primary care, and then so we're taking it away from those areas. So those type of areas came from larger studies, and it was an action research that was going on. And then one of the key things that you start to do is you say, okay, well, how do we vector, right? How do we triage? Because access to care is a very fickle kind of thing that can change at any time, depending on how we do it. So we had to, one, retrain our providers to understand what does care look like. Hey, how many sessions of care do you need? Who are long-term, who are short-term, who are immediate, acute, right? And to be able to learn how to vector them from the clinical provider point of view, but then the second part of, as a clinic, as a team, how do we do that? So each behavioral health, I would say, hospital within the DHA system now does vectoring. What that means is we will review 100% of referrals that come through, or anyone who walks through the Brandon Act. We're going to review them, and then we're going to say, what type of care do they need? What level of care do they need? And is this something that needs to be overburdening the medical system, or can we use the Military Family Life Consultant? Could we use Military OneSource? Could we use the VA's, the vet centers? Because if you're a combat vet and you need short-term reintegration or family support, the VA will still take them. So we had so many different places, and identifying those resources to say, it's not us. Let's send them to Family Life Chaplaincy. Let's send, and so we started to integrate and do those. So then we started to keep the acute levels. So this is where the numbers are going to be skewed, and you're going to start seeing that, because in the behavioral health clinics, you're seeing the highest acuity. Because what we started to do is we started to vector those that don't need psychiatric care, who may need short-term care, or we're going to send them to a CPT group. Right. Or so if you need group-based care and not the individual-based care, or skill-based services like DBT skills for you to be able to handle some of the emotions if it's anger-based or such. So that was one of so you had to do a transformation. But then I'm going to talk to you from a commander's point. So I was recently a commander about a few years ago, and one of the key things is that the Army as a whole changed, not the Army, but the military, changed how a commander's dashboard looks like. So we called it Vantage. It's again, understanding and using data analytics, and starting to use the technology that we have to gather. As a commander, I get notification on their financial status of every member, because I make sure that they get paid, right? So I have direct contact with DFAS on a regular basis. So you're able to do those kind of things. But what Vantage did, it told me when a new person was coming in, I can see if they had a family advocacy issue, if they had a drug and alcohol issue. So again, anything that's happened within the military system or civilian system got fed into that commander's dashboard. And so what that said is that when a new service member came into my unit, I knew how to approach them, what kind of service. So my initial commander's meeting with them was like, okay, hey, how's your family? Because if I knew there was a family concern, how's your family doing? How can I get you those supports? And kind of ensuring that family was taken care of. The second part for commanders is if there was a financial need, right? You can see that if there's any debt, anything that's going on, you're able to see that in that dashboard. And you can kind of say, hey, let me set you up with this financial counselor. We're going to have this conversation. I'll talk to you back again in 3 months and see where we are on your plan, right? Now what we're doing is we're taking it away from the mental health side and innovating it at the lowest level, from the commander to the platoon sergeant to the squad leader level, as the lowest level as possible, to do these interventions. The second thing for command is we did this thing called the Golden Circle. What that means is you're looking at every commander will have, you'll know, I know we talked about, hey, who's the 2 friends you have, who do we contact? So we have your friends, because again, sometimes you have no family members around you. So we're gonna look at who are your friends, friend groups that you're in. If not, we're gonna connect you to those friend groups, making sure you have at least 2 within that area. But the other part is knowing their family members. I called every one of my service members, I called their family members, talk to their mom or their father or their sister sometimes, or other guardian that they grew up with, because again, family systems are very different, right? Whoever they felt was a trusted member that was on their DD-93, which is who they put on their list. And you give them a call and say, hey, I'm their commander. If you have any questions, please call me. And so the military started to change that. So these are all innovations that you won't see at it'll see it at the technology level, but it's at the smaller innovation side of what's happening. So once you take all of that, and now you combine this together, and now coming back to your question of Wounded Warrior and how they know where the services are. As I said, the moment that they come in, we'll touch you, and we're going to tell you what those services are. And those services are, especially if you're part of an SRU or a recovery care unit for Army, Navy, Marines, there's services on a daily basis. We're looking at risk management. We start off at risk management and doing those assessments with you, and it's a weekly assessment that you do. So you have a touch point with at least a squad leader or with a social worker at those times. But from there, we actually put you in for full levels of services. So if you're getting, again, levels of recovery, if you're getting cardiac care, or if you're getting stroke care, if you're getting rehab care, we've integrated mental health into every one of those areas. So for our Wounded Warriors, you don't get just, hey, let me work on your hand. The occupational therapist is working with you with your hand, but the mental health therapist is sitting with you going, okay, how's that experience that you're going through? Because it's hard. It's like, I can't get it. I can't get it to close. I can't, I just want to be able to hold my son's hand. And you're going, okay, well, let's talk about those barriers that you're having. So you have to remove those mental obstacles that are in the way, or help you to refine your goals to get there, so that you can go ahead and hold that can, or hold your hand, your son's hand. So those are kind of the pieces.
It's almost like the data-driven piece is what allows for this precision medicine, or this precision intervention, knowing a lot about a person before you even meet them, and then hearing from them what's important to them. I think we talked about, not just what do you want the end result of your care to be, but who are you, and how do we help you feel like that person, even though you have an injury or you've had this traumatic experience. How do you integrate that? And I know we talked a little bit about virtual reality and some of the opportunities to allow service members and veterans to engage and experience things that they wouldn't have an opportunity to, either because of disability or access, or COVID has took away many of our opportunities to get out and see each other. Sonia, can you tell us a little bit about the work that your organization has done with RAND and some of the virtual reality?
Yes, so there's 2 projects which Combat Stress is running at the moment. One is using VR as part of therapeutic treatment. So this is enabling the veteran to visit particular environments, scenarios, atmospheres, in a safe place with a therapist alongside, so they don't have to be taken to any kind of environment that could simulate that. They're doing it in a very safe place at the pace of the veteran, with the support right there, and it can also be done virtually as well, so you don't have to be face-to-face with the therapist. So that's one piece of work. The other project is looking at the correlation of physical health with mental health through the use of smartwatches, and we know that there is a correlation of sleep, activity, and mental health, and I think we can all relate to that from a well-being perspective anyway. If you enjoy doing physical activity and you don't do it for a while, you can perhaps feel low in mood. So it's trying to look at the science behind that, so that whether there is actually a place for proactive physical health intervention in a treatment pathway, rather than just allowing it to happen perhaps by chance, by motivation of the individual. And then we're very grateful as well for RAND. Through Forces in Mind Trust, we've commissioned RAND to conduct a 9-month study for us. And this is looking at what will be the future role of charities in mental health for the veteran. You know, we're all looking at the same world, the dangers, the challenges and the complexities. And we know that that is going to impact on those who are serving, and therefore what kind of veteran will they be when they come out. So it's a 9-month study. It's looking through, it's using interview technique, horizon scanning, scenario development, in order to then look at outcomes of how do we need to prepare ourselves for that future veteran, with 3 main themes: looking at society, so how are people changing, that next generation, what do they look like, because they're going to be different to, you know, to me as a veteran sitting here today, how technology will play a part, whether that's how generations will use technology and apps, or whether it's looking at the adversary and how they will be using technology. And then that takes us really into the operational world, and what will future conflict look like, what's that operational environment, and what impact will that have on somebody's mental health if they are out there frontline or even back carrying out their duty as well. So we're really, really hopeful about that. That's got a reach out to 20 years as well, so it's looking out to 2045, and we're really excited about what that will look like, so we can adapt our services and, importantly, share it. You know, as we said earlier, you know, we're all dealing with the same human mind. We're all looking at the same challenges of supporting our veterans. And it's important that we are together sharing best practice ideas and talking about it all as well. So I'm excited about that.
Oh, that sounds really interesting. I look forward to hearing to reading the report and hearing about some of the results there. You both talked a little bit about partnering with either a nonprofit or community organizations. And Dr. Campbell, I know that you have the apps in place. Can you tell us a little bit about some of the community connections that the community-based outpatient clinics maybe make to help to provide the mental health services that veterans need but might not be able to access directly through a local VA center or a Veterans Health medical center?
Right, certainly. And so the Readjustment Counseling or Vet Center was mentioned. The CBOCs, the community outpatient centers, are tethered actually to the larger medical centers. And so we have some of those located in our rural areas. We know that's a vulnerable population. Also because of the isolation of some of our rural veterans. I want to mention also that we learned a lot during COVID because we had to roll out telemental health. We didn't have a choice. And what we learned about telemental health is that treatment is just as effective as a face-to-face visit. And especially for our younger veterans who are working and in the community, we can put them in a quiet place in their office and have a session right there and be able to outreach to more veterans. And then leveraging AI, because we know that the administrative burden of our providers is great. We can gather the screening tools and all the data needed so that that data through the use of AI is available to the provider when they're in the office and be able to then do the actual intervention rather than having to spend the time with paperwork and gathering information. Absolutely. And then the VRE, we're learning a lot about that also. Research is indicating, particularly in the area of skills building. So what we call soft skills that are actually life-saving skills. We can leverage VRE for that. And then there's a lot of work happening in the combat stress area with that modality.
That sounds great. And I'm just thinking of ways I'm learning about what you're working on, Josh, and that I would send patients that direction as well, especially the young ones who find so much connection online. And I know that there's, in discussions of an older generation, looking at the online presence of the younger generation, some people, mostly my parents, think it's bad for my kids. But really, it's how they communicate about actual in-person activities they're going to do, keep in touch during breaks from school, and especially during COVID, it's how they learned. They went to virtual kindergarten. So I wonder if you can talk a little bit about your connection to military services and how you are making them aware of some of the services that you provide.
Absolutely. So, one of the things that we do, as you're transitioning out, you lose your community, right? You go from an A to a C, right? Mm-hmm. So you're part of a unit, a team, and you go to C, civilian, where nobody tells you what to do, nobody cares. And so we want to give you a place to feel a part of, to give you that sense of meaning, purpose, and belonging again. And we encourage play. We have 40 different channels in there where if you like AI or drones or specific game, we have that. But one of the tools and resources that we do is we host a monthly summit every month. And it's a get-together where we bring a special guest. So we have a VA rep, so our community is allowed to ask the VA rep anything. So I need to be connected to this service, education, burial services, whatever. So we provide a monthly resource, and that person is in our Discord server, so they could send a message anytime. We have an actual channel in our Discord for VA services. And then we have another one for VA questions. So then if the service member or vet is looking to find whatever that service is, we offer that. The other thing that we do is we also bring on a special guest. So like ACP, they offer mentoring. So as you're transitioning out, I want to be a photographer. Well, they've got like 10,000 photographers. Or I want to be an NFL agent. They have agents. I want to be an attorney. They have attorneys that they'll partner with. So every month we bring a different guest on from the community of different services. There's 40,000 different VSOs. So we try to pick some of the top ones and invite them to offer the services so that our entire community knows, okay, here are the resources. Because you don't know when you're transitioning, you don't know what's out. How do I sign up for VA care? Yeah. How do I do this? How do I want to be a doctor. How do I even start that process? Oh, here, we'll connect you. So by being a part of the community and by participating in our monthly sessions, it allows you to have access to those services. So that's like one of the main ways that we do it.
That's great. And also sort of just from the privacy of one's own home or comfortable space.
You don't have to go anywhere.
Yeah. You can find out what you need. So, Sonia, you talked a little bit about like the saturation of veteran services, and I know that we have a similar issue in the U.S., and especially with people who have local programs for veterans in Virginia and veterans in Virginia Beach, it's very specific places. And I'm thinking about the ways when we talk about connection and when we talk about innovation, yes, we have the full list of everything available, but I'm thinking about ways where you can really come up with a bespoke set of resources for a veteran without them having to tell you specifically, I want to do this and only care about this particular route, but also for parents who are navigating parenthood and perhaps pregnancy, as we talked about, having served and not having that shared experience with maybe other moms or other people. The question I have for you is there integration among some of the nonprofits and some of the services in your community in the UK?
So I think there is to a degree, but it's been recognised by the government that there does need to be more. So there is a review ongoing at the moment called OPVALA, which is looking at how does the UK support its veterans. So it's a very grassroots to strategic review, looking at all the needs of the veteran, what currently is out there to provide them with support, and how well cohered and coordinated is that, but absolutely how is that linking into the serving person's world, because it does need to be seamless so that you don't sort of fall into these traps of losing people along the way or making the environment so different from serving to then civilian. So there is a lot of effort going on, particularly between the military charities as well, to find where their place is, what are their skill sets, where are they best placed, how can they mesh together rather than be in competition with each other, which is always with good intent, but not perhaps best for that serving person or the veteran at the end of it as well. So I think it's almost a good problem to have, that there are lots of organisations that are wanting to help, but I think there is still a need for us to be better coordinated, better cohered, and I think that's definitely where AI can help with that as well, particularly with the number of helplines that we do have.
Absolutely. So at the end of this panel, I want to give each of you an opportunity to share a call to action. If we want to ask our legislators and our government, especially in the end of the fiscal year, when we're looking at funding for programs and funding for services provided by the government, as well as services